Good afternoon. On behalf of the Expert Committee on Communicable Diseases, I warmly welcome you to the Symposium on Tuberculosis, the Scourge of Victorian Britain, a glimpse of the present state of affairs. May I cordially invite Professor Jennifer Pereira, Consultant Microbiologist, Past President of SLMA, and a member of ECCD, and Dr. Manilka Sumanathilaka, Consultant Endocrinologist, President of the Sri Lanka Medical Association, to chair these sessions. Over to you, Madam.
Good afternoon, everybody. I warmly welcome all of you to the 12 o'clock symposium of the ECCD, which is now, this time the theme is on tuberculosis. As all of you know, we celebrated the World TB Day yesterday. So, and in view of that, and we know that the disease is increasing in incidence, not only in Sri Lanka, but all over the globe. It is one disease that we could not control satisfactorily in this country, because we have made many milestones with regard to infectious diseases, such as we have eradicated many diseases, like malaria, which is a very difficult disease to eradicate when we have the vector and the parasite both and the suitable environment. So, but TB is still a problem in this country. So it is timely that we revisit this topic so that we get updated in terms of knowledge, and also spread the message that TB is still a problem, because still people tend to underdiagnose tuberculosis, and especially in children. And we have invited the pediatrician also to contribute to this symposium. So without further ado, may I welcome our president. Presidents normally don't attend our symposia. Normally a delegate from the SLMA comes. So I understand TB is very important. That's why the president of the Medical Association is also here in spite of his very busy schedule. So we will start with the presentations. And would you like to introduce the first speaker, Manilka?
Yes. I try to be present and encourage all the subcommittees. Plus, TB is very important from my point of view also. Most of the people with tuberculosis have diabetes, and there's a high prevalence between the two diseases. So we are, screening in our clinics also for tuberculosis. Now we are undiagnosed. That's the problem. So now the first lecture is by Dr. Sumal Nandasena. He is a specialist in community medicine and public health, Deputy Provincial Director of Health Services, Western Province. He will be talking to you on tuberculosis, an update on the current situation, the targets, challenges, and the way forward in Sri Lanka. Over to you, Dr. Nandasena.
Thank you so much. It's all right, okay. So without further ado, I'll start the presentation. So I'll be right, thank you. So very quickly, I touch upon few areas, first starting from the current epidemiology, then some of the few important concepts of the tuberculosis and the challenges that we are facing today, and the way forward, what we have to face in the next decade time. So as Chairperson very correctly said, now why tuberculosis still matters is an important question for us. So because it's leading infectious disease globally, and probably the second leading infectious disease in Sri Lanka, probably second or third, just after the dengue, after the leptospirosis, or even before the leptospirosis as well. So, and importantly, it is preventable and curable disease if we tackle the problem correctly, and it is one of the diseases we will able to be away from in the next decade of time if you collectively do the needful. So what it globally says is 10.6 million people have developed the TB. There are about 1.3 million deaths happens annually. And importantly, more than 80% of these cases are from the middle income countries or low income countries. So if you focus into Sri Lanka, so there are a lot of statistics about Sri Lanka. So this is one of the areas in the Ministry of Health having good statistics though. So I'll be just limit everything into one slide because I think next few minutes I should focus into some of the important areas looking into the future. So yearly, usually we report about 8,000 to 9,000 cases. So, and there will be about 700 TB deaths happens yearly. And the national rate is going to around 40 per 100,000 population. But when it's come to the Colombo, it's be even more than 80 cases per 100,000 population. That is because the Western province, which I'm coming from, and I'm also the authority for the administration, but still about half of the population, half the TB population is coming from Western province. And out of it, almost the half from the Colombo district, and the majority of the half is from the Colombo CMC. So that is how the distribution goes up. And one of the important things I want to highlight here is that the age category that the TB is having in the recent years, where 65 years and above gets almost 1/4 of the TB cases out of the entire TB positive population. So it's well tally with what Dr. Manilka was saying previously. I will show you one of the slides as well as it goes. Nevertheless, we have a good system in Sri Lanka where we are proud of all the time. We have a dedicated national program, district test clinics, and the TB control other units as well, and the inboard facilities as well, with the hospitals, laboratories, dot centers, and also link up with the public health system as well. So it makes a good kind of achievement for us, but there is a long way we have to go. So when we looking into the achievements, we have a good treatment success rate, which be more than 80% of the country, and well-established surveillance system, though itself having some inborn problems with, because we are running up with the hard copies and the information system may not that updated with the digital era, but there is still a good system in place compared to the many other countries in the world. And all the services are free of charge, including the consultations, diagnoses, and the treatment service. Everything is free actually for our country. And having a strong chest clinic network as well, where there is at least one clinic across all the districts. So makes a good system though, and integrated with the preventive health system as well. Having said that, we are facing the challenges as well. So these challenges are very bold, and it's known most of our audience, distinguished audience, but let me quickly go through, because we may kind of looking into one of the focus challenges to make our shape up our future dimensions in the TB control. One problem is that regarding the clinical and diagnostic challenges, delayed in diagnosis. That is happens because it's inbuilt with a lot of health system issues, as well as resource limitations, as well as sometimes the ignorance of kind of community, as well as from the not getting diagnosis correct at the correct time by our own medical community as well. So underreporting happens, fragmented reporting system is there. I'll show you one example. And the private sector involvement in controlling TB has to be developed, and it's a challenge that we have to face, and the limited digital system. And when you go to looking at the social system, so the stigma and delayed care seeking is still happening across the country and among the people who are suffering from TB. And even sometimes that the people will not happy to say that they are having a TB, or may not follow the rules and guidelines or the advices which will give from the medical system. And poor treatment adherence as well, and urban poverty. So, and vulnerable population. That makes the more incidents in the Colombo as well as some of the CMC area. If you really focus into where these cases are coming from, it's mostly from the low socioeconomic population scattered around Colombo CMC area. That is how the number is going up. So recently, a national program conducted a survey. It's called Care Pathway Analysis, which come up with some of the good results, and shows that the reason for challenges as well, and it shows that there's a significant gap in case detection, and which caused having large missing TB patients. I'll show you in detail in future in the next slides as well. And there is a delays in diagnosis and treatment. Once diagnosis, treatment is not immediately started. If the median says it's 21 days, according to the survey results, this include more than 700 patients who had TB, which was completed very recently. And mind you, about 20% of the patients turn up with the treatment even after 1 month. So it makes once the diagnosis and hanging around, and they are not adhering to the treatment and started the treatment. And there are gaps in the private provider involvement. If you go into detail, actually, we know that the health system in Sri Lanka, about 50% of the primary healthcare delivers by the private sector. And if you look into this particular problem, that the patients has gone into private sector, the different levels of the private sector, but majority were not diagnosed at the first instances, and they have repeatedly gone to several doctors only. Then they have identified that they are having tuberculosis. That may be due to different reasons. Maybe diagnosis issues, laboratory issues, and not thinking about the TB much by the medical doctor. And there may be certain other issues as well. So, and missed opportunities in early diagnosis is also there, because that I think clinicians will discuss a lot. Sometimes the symptoms may be asymptomatic, may be difficult to identify the patients initially. That may be also wind up with this lack of identifying the patient at the first instances. Now, I'll show you a very important slide here. This goes up with what Dr. Manilkar's remarks as well. Now, here it compares the population of our country from 2012 census and 2024 census, where the 2012 census says that there are about 25.2 young population proportion is there, which has reduced over the time. At the same time, elderly people have gone up. So it has increased by 4.7 percentage points, and it's continuing. This is 2024 data, but the projection is quite alarming. It's going, the elderly population of the country is going up. Now, what the TB says is, TB statistics says is, in 2012, when it go to the all TB population, only about 50% had the tuberculosis, where now it is, according to 2024 data of the TB campaign, it's 25% of the entire TB population, TB patients population, entire thing, 25% is from the elderly group. So it's alarming rise of the TB among the elderly in one hand. On the other hand, it is because the socio-demographic shift happens towards the elderly population in this country. Now, as Dr. Mallika said, it's a diabetes and tuberculosis. It's an important subject today, and it will be a very important subject in future as well, and something we have to focus a lot, because meta-analysis says that the 3 times higher chance having to have a tuberculosis among diabetes patients. So now we can link up with elderly and diabetes. And we all know that when elderly happens, elderly population goes up, diabetes population also going up, percentage also going up. So there's probably there may be higher chance to have a higher number of TB in future with this, if we are not having a kind of very efficient system working and screening those who are having the tuberculosis in future. So elderly may have some other comorbid factors as well. They also synchronize with the disease conditions as well. Now, I said that the reporting systems and the information system is fragmented. Though it is, I said in one hand, I said it's very good. In one hand, I said it's a fragmented. So there's a one kind of example that I'm able to show ourselves, myself and Dr. Ranjan, we all together did a small study. So where we notice that there's a TB deaths number which reported from the national program is quite different from what is reported from the Registrar General Department. It's not just a 1 or 2 cases, it's about hundreds of deaths which identify the National Registrar General Department is different from what is reported from the National TB program for the due to several reasons. That may be the national program is reporting deaths only those who are in the treatment cohort, where when the treatment is not started, they are not in there. And maybe some TB deaths or TB patients are identified during the post-mortem as well. Or maybe some patients are not taking treatment at all. And also there, on the other hand, there may be misclassifications as well, because many of the TB patients maybe died in their homes as a home deaths, where the diagnosis and the declaration and the final ICD coding will be done by the lay people. So there may be so many misclassifications, and there may be kind of places where which goes wrong. So because of that, the information system is a bit of fragmented and which not gives a real value of deaths which we are having. And the bad part of it is, now WHO, when they are doing their estimates, they are looking into these deaths numbers which we are happening in our country and which is reporting by us. They also make the estimates based on that, which gives a kind of higher value for all of us all the time. And importantly, the missing cases. So here shows that from the 2005 to 2025, deaths, TB cases which are reported from the TB program, where it shows 8 to 9,000 cases every year. But at the same time, WHO estimate that the Sri Lankans, the TB population is about 14,000, which gives a gap of 4,000 to 5,000 almost every year. So, in other words, what it says is that we are missing some patients who are having the tuberculosis. Or else other prediction that we will be able to get, WHO estimate is having some certain problems, but it is kind of an internationally accepted method, but still we have the issues with the information system is as well. So we will not make a big argument that the levels that they are predicting is wrong. Mind you, with these all aspects, then we have the TB targets here. So what it says is it gives the NTB target 95% reduction in the TB deaths in the 2035 based on the baseline values which were reported in the 2015, and 19% reduction in TB incidence and catastrophic cost to be 0. Can we achieve that? So these are the values, the baseline values, and the current situation. Actually, here I'm citing 2023 data and NTB targets in the right side. So it's like a bit of ambitious for us. And if it looks like it will not be capable of achieving all these goals as we go, and the challenges that we are facing in future. And I did a little bit of prediction based on the values which I received from 2005 to 2025 and did a projection up to 2035, and notice if I do this business as usual, if I do the same system and going looking at the patient, doing the surveillance in the same system, what is happening right now, we will not ended up in the NTB targets, but we will have at least 7,000 cases by 2035. But this may be more than this based on the elderly population increase and increase of the non-communicable diseases. So, ladies and gentlemen, since I am getting too much of time, so very briefly, these are the way forward slide, which shows that we have to intensify our early case detection. We have to integrate TB with NCD and elderly care. So what it means is we have, when, as Dr. Malika says, that when there's an NCD, we have to think innovatively how we are doing on the screening for the tuberculosis, not in one place, but across the whole health system. Strengthening the diagnostic capacity and improve treatment and adherence, and engage private sector is quite important. As I said earlier, 50% of the primary health care provided by the private sector. And data-driven surveillance and accountability is important. In other words, that the information system should not be fragmented and should be uniform system. And policy and investment acceleration is quite important. Now, being I'm a public health person, I wish to show you as the one of my last slides, this one, preventive sector and curative sector. If you see this left side picture, it shows the sink where a tap is there, and there's one person who is doing the wipe of the floor. So the sink, the sink is not functioning properly, which is tally with the preventive health system, so there may be overflowing of the cases of the problem, where the clinician who is pretended here as the wiping person will have more work. So in other words, that the public health system, preventive health system, to work hard to prevent and control the disease. Then only the clinician will have a manageable amount of work where he will be able to give a quality work. If these two systems will not work in hand to hand, then there will be a problem for us, and the burden for the clinical sector would be high. And importantly, we have to think about the primary healthcare system. We cannot just think about our 405 district chest clinics and the district and the wards. So we have to think of the primary healthcare system at the grassroots level. We have 1,100 primary healthcare institutes in the country. And new concepts, there are the Arogya is coming now. It's include another 1,000 centers, where all these centers would be able to use for certain aspects of the TB prevention and control. Not every aspect, because certain things will need the specialist management and so on. And even the drug distribution has to be very stringent, otherwise there will be issues about drug resistance as well. But there are places, there are management line we can think of utilizing this system as well. So, and the continuum of care will happen with this primary health care and the specialist care if they are continue together and work together. So thank you so much.
Thank you very much, Dr. Nanse. You take question. Okay, can introduce the next speaker. Okay, the next speech will be on microbiological and laboratory diagnostics in active and latent tuberculosis by Dr. Vatsala Galagedara. She's the consultant microbiologist at the National Tuberculosis Reference Laboratory in Valisara. Over to you, Dr. Galagedara.
Good afternoon. Thank you very much for the opportunity. So the topic given to me today is to talk about microbiological and laboratory diagnosis in active and latent tuberculosis. So this would be the outline of my talk during this coming 20 minutes. So a little bit of microbiology. So human tuberculosis is caused by we tell it's M. tuberculosis complex, Mycobacterium tuberculosis complex, which comprises of 9 species. So these 9 species are more or less genetically very similar. So in clinical practice, we don't differentiate them. We report as Mycobacterium TB complex in our lab reports. So what is specific about mycobacteria, not only Mycobacterium TB, other mycobacteria, like mycobacteria other than TB, and also what we call MOT or non-TB mycobacteria, which is called NTM. All of them stain positive with acid-fast staining. So because of the high molecular weight lipids in their cell wall. So I hope you can see the nice pink color beaded, elongated mycobacteria bacilli in this background. And the other specific thing about this mycobacteria TB specifically is their growth is slow when compared to the bacteria we know of, Staphylococci, Streptococci, Enterobacteriaceae. Their generation time is prolonged. That's why it takes about 3 to 8 weeks to give a visible growth on solid media. So few important points about the transmission. So these are, we call Mycobacterium TB, tuberculosis is airborne pathogen. So it is spread by inhalation of droplet nuclei. It's very small particle. The diameter is less than 5 micrometer, which is aerosolized from patients with pulmonary TB during coughing, sneezing, talking. So this is an illustration of the pathogenesis. It's not the letters are small. So I hope you can see the two disease, like two entities of the disease. One with active tuberculosis disease, actually what we say disease. And on the other hand side, it's the latent tuberculosis infection. So in this latent tuberculosis infection, radiologically, microbiologically, and symptom-wise also, the patients are it's negative. So chest X-ray normal or normal. If we perform microbiological tests, they are normal and they are symptomatic and they cannot spread the disease. On the other hand, active disease is where we have to catch these patients with pulmonary TB to prevent the spread. So this is the diagnostic algorithm prepared by the National Program for Adult Patients with Pulmonary TB. Patients with presumptive pulmonary TB are known as cough. So they're having cough more than 2 weeks with or without constitutional symptoms like evening pyrexia, loss of weight, loss of appetite. And in immunocompromised and elderly, it is known that cough for any duration should be considered because they are more prone to get tuberculosis. So as indicated in the algorithm, chest X-ray is a main screening tool, and along with the sputum AFB. So this doesn't need introduction. Actually, this is a very old method. We are known for a long time. Less expensive method for diagnosing pulmonary TB, developed more than 100 years ago. So we ask for 3 sputum samples because of the less sensitivity it has. But with 2 smears, they say it can reach up to more than 90%. But and it is also said we need 5,000 to 10,000 bacilli per microliter to give a positive result with sputum microscopy. That's why it is said to be less sensitive. The other disadvantages are we cannot differentiate from MOT, NTM or Mycobacterium TB with this AFB stain. And it largely depends on the staining technique and the experience of the microscopists. That's why we need this external quality assurance programs and regular training for the PHLTs. We cannot detect drug resistance with sputum microscopy, and also it performs very poorly in this postbacillary disease like extrapulmonary TB and pediatric TB, which I will later mention. So these are the latest WHO recommendations. So WHO recommendation, they advice is to go for a molecular test as the initial diagnostic test rather than smear microscopy and culture as the initial in a presumptive TB patient. And also for detection of rifampicin resistance, also their recommendation is to go for molecular test rather than culture-based DSTs. So this is not possible for us to implement all around the country, but at the moment, program has implemented that in Colombo Chest Clinic, which is under their administration at the moment. So these are the this molecular test I mentioned. So they are called low complexly automated NATs. NATs stand for nucleic acid amplification tests. So also the WRDs. WRDs stands for WHO recommended rapid diagnostics. So the WHO recommends 2 tests to be used as initial tests. Fortunately, the National TB Diagnostic Network have both of these molecular tests in the country. So the Expert MTB RIF Ultra, the Expert MTB RIF is the previous version. So we have that since 2014, and TrueNat MTB Plus is also in the country, introduced last year, with the machines brought down to the country for COVID testing. So it's further details about Expert Ultra. So we have all the cartridges we have in the country are Expert Ultra. Now with a level of detection, so it's 16 colony-forming units is enough to give a positive result with Expert Ultra. And we can test both pulmonary and extrapulmonary samples with this Expert platform. And both of these tests take only 2 hours. So about this TrueNat MTB Plus, it is again more or less similar with the sensitivity to Expert Ultra, but there's a slight reduction of sensitivity. As you can see, 29 colony-forming units per ml to give a positive result. For this TrueNat MTB Plus, at the moment, we are recommending to use only the pulmonary samples as per the WHO recommendation. So this is the sensitivity specificities for pulmonary TB, these molecular tests. So you can see to detect both for MTB and also for rifampicin resistance detection, the sensitivities are specificities well over 90%. But this is for pulmonary TB. These values differ greatly in pediatric and extrapulmonary specimens. So I have given possible results for a This is mainly for gene expert, but the only difference with when it comes to a TrueNat result is we don't get a trace result with the TrueNat. So first we get the quantity of the Mycobacterium TB. So it is important when documenting to document the amount, whether it's a high, medium, low, very low, or trace, because we can have an idea about the bacterial load in the sample, patient sample. And also rifampicin resistance can be detected, not detected, or indeterminate. It is important to know, as I mentioned earlier, because MTB detected very low and traced results can be there even for a patient, because we detect the DNA, not the viable bacilli with these molecular tests. So it is important to, can be positive because of the previous treated patient because of the dead bacilli. So in these occasions, we asked to send for a culture to see the viable bacilli. And when we get the MTB detected trace result, the rifampicin resistance will always be indeterminate. The machine can't detect the rifampicin status when the bacillary load is very low, that low, where it gives a trace result. So these are the places. This is available in the NPTCCT website. We have 28 gene expert centers with 35 machines all around the country, where we have given the priority to Colombo district. Colombo district have 5 machines at NHSL, LRH, Colombo South, Medical Faculty Colombo, likewise in Alvalicada prison. So we have 5 machines. So we have given priority to the high burden districts. This is the TrueNat, which we started at in 2025 with the machines for COVID testing. So that is also, it's almost 12 TrueNat machines are there with testing for tuberculosis. So as per this, our diagnostic algorithm, chest X-ray suggestive of pulmonary TB, 3FB negative, gene expert or TrueNat, this molecular test negative. So what would be the next step? If still suspicious of pulmonary TB, then where our cultures come into play. Actually, not only in these situations, there are some indications for culture which I have not included here, like pediatric TB, extrapulmonary, presumptive MDR. Those occasions also you have to send for cultures. So we have both solid LJ medium, which is known as LJ medium. So we can see the nice blue color medium. It is an egg-based in-house medium we prepare at the NTRL. And we have this liquid culture BD Bactec Midget system that is also a commercial system. So still the culture is considered the gold standard because even 10 viable bacilli can be detected by these culture methods. So these liquid cultures sometimes are known as rapid cultures, but there is sometimes a misconception with rapid cultures. We can give the result in 2 to 3 days, but it's not like that. Depending on the bacterial load, we might be able to issue a positive result in 10 to 14 days, but to issue a negative report, it takes 6 weeks because the tubes are incubated in the machine for 6 weeks. So this is the newer platform actually introduced to NTRL, the network in 2023. So same gene expert platform, but a different cartridge. This has replaced the line probe assay, which detects this isoniazide and fluoroquinolones. This is not routinely done like gene expert or TrueNat. Because anyway, our resistance rates are low, even the rifampicin resistance less than 1%, and isoniazide monoresistance is also less than 1%. So this is not routinely done, but in delayed conversion, it depends on the clinician's judgment. We can do this at NTRL. So few points about EPTB diagnosis. So EPTB, again, a postbacillary disease. It's very challenging despite these advances in imaging and diagnostic tests as well. So we have to use a combination of several tests for EPTB diagnosis. And few important points about pediatric TB also. This is again a diagnostic challenge because children have possibly TB, and also because it's challenging to collect appropriate samples from children. So the gastric aspirate is the well-known sample, not very much accepted by the parents. So child have to get admitted. And even this, so I mentioned about the sensitivity, specificities, these even these molecular tests are less sensitive in this pediatric sample. So that is a challenge. So these are the respiratory samples for pediatric pulmonary TB. So even stool is a newer sample. The recommendation from WHO is to combine both the respiratory and stool to increase the case detection. So this is about urine lamp, where people sometimes take a lot of interest in. So at the moment, the recommendation from WHO is to use only in HIV positive individuals. At the moment, no recommendation to be used in immunocompetent individuals. So it is a urine antigen which can detect mycobacterial antigens in the urine. So if it's a HIV patient, inpatient, the recommendation is to use in CD4 less than 200, outpatient CD4 less than 100. So again, to increase the case detection, the advice is to combine both respiratory and urine lamp. So something about specimen collection and transport. We should have this wide mouth, clean and sterile screw cap containers for these TB specimens. Screw cap is important. Earlier we used this as a yogurt cup like container for this microscopy, but it is now replaced with a blue top screw cap container. So what is important is we need good quality samples. The program is spending a lot of money on these molecular tests. They are very expensive, but it is very important to advise the patient to produce good quality samples. And especially when sending EPTB samples, we need a sterile normal cell line to prevent drying. And the other challenge of EPTB is we receive very small biopsy samples, so it might be falsely negative because of the sample size. So these, I have mentioned about this National Diagnostic Network under the NPTCCD. So 4 intermediate TB labs in the country. So we get solid cultures where probable MTB suspected for confirmation and DST to NTRL. So the gene expert TrueNet I mentioned. So there are 26 district test clinic laboratories and nearly 200 microscopy centers where in DHS, BHS, where microscopy is available. So this is something about this NTRL under the NPTCCD, situated at National Respiratory Hospital premises at Valisara, but is under the administration of national program. The MRI doesn't do any culture work at MRI. It's only the Colombo Chest Clinic is situated there with 2 gene expert machines. So for mycobacteria, TB or mycobacteria other than TB, you have to send cultures to the NTRL. So TB infection I mentioned just before this discussing about diagnostic testing. So diagnosing LTBI, there is no gold standard test for diagnose TB infection or latent TB infection. What is important is ruling out the active disease with proper microbiological sample collection. So these are the tests available for LTBI diagnosis. Tuberculin skin test, or which is the MAN2 we are familiar with, and IGRAS or interferon gamma release assays, and this is newer MTB antigen-based skin tests. So from all these tests, we measure the immune response, immune sensitization to the previous mycobacterial antigen. So the immunity of the patient is important for a good result. So tuberculin skin test or this MAN2 uses purified protein derivative. So because they are from heat kill cultures of MTB, there is a cross reaction with BCG vaccine. But this newer IGRAS and antigen-based skin test, they use this specific ESAT6 and CFP10, where there is no cross reaction. So they are said to be more specific, but the sensitivity is same. So these are the IGRAS, WHO recommended IGRAS, quantiferon TB Gold, T-spot test, and one-tie TB IGRA. And this is the antigen-based skin test I mentioned. So this ITB available in the country for a project. So it is available in Gold district at the moment. So about this TB infection test, what is important is they should not be used to investigate for active disease. So there can, because it measures the immune response of the patients, so there can be a false reassurance to the clinician if we get a negative result. And these are the summary points I wanted to highlight. Thank you.
Okay. Thank you, Dr. Vatsala, for that comprehensive narration about the new diagnostics available in the country. And we move on to the third speaker, Dr. Niranjan Disanayake, who will be speaking to us on clinical presentations of tuberculosis, understanding complexities, and navigating towards a confident diagnosis. He is currently the consultant pulmonologist at the teaching hospital in Kadutara and also serving the district chest clinic in Kadutara. Over to you, Niranjan.
Thank you very much, Madam. Dear chairpersons, dear colleagues, and thank you very much for the opportunity given. And I would like to thank Dr. Ranjit Pereira for his leadership in arranging this important symposium together with the SLMA leadership. And as we know, tuberculosis as clinicians is a major challenge. And sometimes this challenge keeps us going. I will be discussing about the challenges that we face regarding the respiratory system, and we'll try to apply these to the other extrapulmonary tuberculosis as well because of the lack of time. So why do we need a confident diagnosis? So what is actually a confident diagnosis with regards to tuberculosis? A confident diagnosis in tuberculosis is that you have to prove that there is viable bacteria in tissue so that we can prove that the patient is having what we call active tuberculosis. So as Dr. Vatsala correctly said, the culture is the gold standard, but unfortunately, sometimes the culture sensitivities are low and it will take at least 6 weeks to come. Hence, sometimes as clinicians, we are pressed to start treatment for these patients as early as possible. And this is a very good example of not treating tuberculosis. This is not in pre-drug era, that is before 1940. This is in 2024. And it's a young patient, 26-year-old, who presented unfortunately to us. And we can see the devastation of the lung of this patient. And if you look closely, the patient is already on inotropes. And the patient has had symptoms for the past 6 to 8 months. But unfortunately, due to patient factors as well as doctor factors, the patient has not been initiated in appropriate treatment. And hence, the patient came to us like this. And this patient, we couldn't save whatever we did. So even in the drug era, where we have effective drugs which are given free of charge to our patients, this happens. Now, in the pre-drug era of tuberculosis, especially a patient with pulmonary tuberculosis, smear-positive pulmonary tuberculosis, there is a tendency, at least 90% of the patients died within the first 10 years of diagnosis. And most of them died within the first 2 or 3 years. But later, because of the complications of tuberculosis, majority of them died. Things are a little bit better for smear negative tuberculosis, but the untreated tuberculosis has a high mortality. And the other thing is, especially with regards to pulmonary tuberculosis, when a patient is having smear positive pulmonary tuberculosis, or even negative tuberculosis for that matter, this patient can give the disease to another person. Now, the studies have shown that this is from the WHO site, a positive tuberculosis who is untreated can at least give this disease to 15 people. It depends on the social factors. It might be different in areas where there is a little bit of less congestion. But if the patient, especially in children, I'm sure that Channa will allude to this, especially children, patients who are having immune deficiencies like uncontrolled diabetes, the tendency to develop tuberculosis and transmit tuberculosis and get tuberculosis is very high. So those are the two important things with regards to tuberculosis not being treated. But at the same time, if we don't have a confident diagnosis of tuberculosis, we might overtreat tuberculosis. Now, I think most of our clinicians and colleagues will agree that in the right side, it looks like biliary tuberculosis. But this is adenocarcinoma with secondaries in a 27-year-old young man. And in the left side, left upper zone opacity, the first diagnosis correctly, we should think about tuberculosis and we have to exclude it. But in this patient, this is chronic pulmonary aspergillosis. And in the right side lower zone, this is one of our patients as well. We can see like a tree in bud appearances with the right side middle zone opacity. And we have extensively investigated, including a VATS biopsy, which proven to be as sarcoidosis. So tuberculosis can mimic certain things. Hence, if we treated this young patient with anti-tuberculosis drugs, two things can happen. One thing is we will be delaying the patient's diagnosis unnecessarily while treating for tuberculosis. The second thing is, as you know, all tuberculosis drugs have significant side effects, including fatal side effects like DRESS syndrome and fulminant hepatic failure. These patients can have unnecessary complications of drug treatment. Hence, it is very important that we diagnose tuberculosis confidently, ideally bacteriologically proven, and treat them as early as possible. But at the same time, we should exclude tuberculosis and think about the other possible diagnosis in these patients to prevent unnecessary harm that occur in these patient groups. Right. So, but it is challenging. Tuberculosis is a challenging bacteria, and that is why I have a huge respect for Mycobacterium tuberculosis as an organism and as a living being. Tuberculosis symptoms are non-specific. If you look at the symptom categories of tuberculosis, the most of the symptoms that we say, well, the commonest is cough. And if you just sit in your private sector or is in the OPD, majority of the patients who come to us will complain of cough or respiratory symptoms. But most of them will have simple viral infections, post-viral upper airway cough syndromes, or other conditions, gastroesophageal reflux disease, maybe asthma. So it is a very, very, very non-specific symptom that we are trying to diagnose, getting to diagnose tuberculosis. And sometimes these patients say, Mata samanya gasak thina. So sometimes they will not come out with the cough as a symptom. So how would you navigate this problem? But the most important thing is to have a high degree of clinical suspicion. So this patient, a 38-year-old, had cough for 1 month. And rather than just treating for this cough with some cough syrups and some antibiotics, and unfortunately, some of us are using drugs like levofloxacin and moxifloxacin, which might partially treat tuberculosis to a certain extent. The most important thing in the periphery or as a general practitioner or as a doctor is to do a chest X-ray, which is freely available in Sri Lanka. And it is very, very, it helps us in diagnosing these patients. And sometimes we might diagnose a malignancy or another condition as well. So this patient proved to be he had hoarseness of voice as well. Hence, we went ahead and did a bronchoscopy in this patient. But this patient proved to be having TB larynx. We can see the small nodules as well as tuberculosis of the lung. So cough, even though can be non-specific, but if we use the correct diagnostic tools, will lead us to the correct diagnosis. But at the same time, sometimes all the investigations can be negative. This 27-year-old boy actually, came to us with unrelenting cough after COVID. This was when I was at Ratnapura. So CT was negative. HRCT was done, it was negative, but the main complaint of this chap was cough. So I'm not very sure. So, and the bronchoscopy revealed this hemorrhagic mass, and we thought it is possibly a malignancy, but the biopsy came as tuberculosis. And we did the repeat bronchoscopy after starting ATT in about 6 weeks' time. It was completely cured. So if a patient comes to us with cough recurrently, then I think always we have to investigate thoroughly these patients with all the investigation facilities that are here with our momentum. Then we will not be able to miss these patients' diagnosis. So the message is that even non-specific symptoms, if thoroughly investigated and excluded other possible diagnoses, they can lead to tuberculosis diagnosis, a confident tuberculosis diagnosis, and these patients will be able to start on appropriate treatment. So if the AFB is negative, acid fast bacillus is negative, is it not tuberculosis? Sometimes we have referrals where the patient have changes, but the acid fast bacilli is negative. So sometimes this can be negative because the patient is not giving a proper sample. And there are many instances, as Dr. Sumal Nansen highlighted, there are elderly people with comorbidities coming with poor conscious level. They can't actually produce a sputum sample, even though there are large opacities in the lung, where we need to actively try to take a sample. One thing, like in children, what we do is we usually put an NG tube and try to get a gastric aspirate in children. Is suspicious is there. And even in the elderly population, if the patient is unconscious, we can use these methods to diagnose tuberculosis. Rather than just saying this is AFB negative, it is unlikely to be tuberculosis. And as Vatsala correctly said, acid fast bacilli sensitivity is very low. You have to have at least 10,000 bacteria per milliliter to get a positive acid fast bacilli. Hence, we can use the nucleic amplification tests at our disposal, which have a high sensitivity to detect this tuberculosis. Now, this patient, a right side upper zone opacity, smear negative. He was an ex-smoker and has a past history of tuberculosis as well. Our problem was whether it's a recurrence of tuberculosis. But importantly, this patient denied having loss of appetite, loss of weight, night sweats, and leaving pyrexia. And the right side shoulder pain was rather unusual to have tuberculosis. And if we look closely, we see the erosion in the second rib, and there are some nodules in the lung as well in the left side. So we were thinking about the possible other differential diagnosis. Sputum AFB was negative in this patient. Sputum for nucleic amplification test, gene expert, was also negative in this patient. Right. Sorry. And this patient has clubbing. And we did actually a bronchoalveolar lavage in this patient. Bronchoalveolar lavage revealed very low percentage of gene expert positivity, Mycobacterium tuberculosis. So here in this patient who has a past history, we know that sometimes gene expert or nucleic matter can coexist or exist in these patients for very long times. Hence, whether this positivity is significant, in this patient, it has been 5 years, but it is not trace, it is very low. And ideally, we send the bowel sample for culture, which became as positive later after 6 weeks. This was taken as tuberculosis reactivation. Fortunately, the patient didn't have rifampicin resistance. But because of the other factors, we continue to investigate this patient. And ultrasound chest revealed a hypoechoic mass in the right side apex. There was a mass encased in the vessels. CT chest suggested a malignant mass. The bronchoscopy was negative because we couldn't reach the periphery of the tumor, and we sought help of our brilliant thoracic surgeons. I think I have to pay homage to them. We have 4 or 5 brilliant thoracic surgeons who are helping us immensely in managing our patients. And the diagnosis was infiltrative adenocarcinoma. So this patient has coexisting active tuberculosis plus a malignancy. Hence, it's very important to use all the modalities in our armamentum, and we should not stop at a single diagnosis. Certain diagnoses can coexist as well in these patients. So when the AFB is positive, acid-fast bacilli, we know that because it's the thick mycolic acid containing cell wall, it is sometimes positive, but there are other groups like non-tuberculous mycobacteria, but there are other non-mycobacterial organisms which might be positive for AFB as well. Hence, probably it is not always tuberculosis. In the context of Sri Lanka, we have done a study with the Peradeniya University, Champa and myself. We found that about 99% of the 5%, 5% of the people who have AFB positivity, who are from the community, has actually tuberculosis. But especially in a patient who is having underlying bronchiectasis, and especially the patient is having past history of tuberculosis and disrupted lung, we have to be careful because of two things. One thing is they can be non-tuberculous mycobacteria. Another thing is, even if it is mycobacterium tuberculosis, there's a high risk of developing drug-resistant tuberculosis. Hence, we might have to use other modalities of diagnosis, including the gene expert nucleic amplification test to exclude rifampicin resistance, as well as the XDR tuberculosis and TB liquid culture and other ABSTs to detect these patients whether they have other problems. So in this patient, actually, this patient has been treated for tuberculosis 3 times in 2019. In this era, we didn't actually have the gene expert because we couldn't get the gene expert to Sri Lanka because we didn't have the money. And now in this patient, the culture is negative twice. But if you look at the third episode, this patient's AFB was positive, but the gene expert was negative. So when the AFB is positive and the gene expert is negative, that means this bacteria, which is stained by the normal acid-fast bacilli, is not tuberculosis, because the genetic material that is there to signify tuberculosis is not there. So even though the sensitivity of my gene expert might be questioned, especially when you have previously had tuberculosis, especially when it is traced, but if in this context, if we say gene expert is negative, it is most likely this AFB bacteria is not tuberculosis. It's most likely mycobacteria other than tuberculosis, which was proven by the whole genome sequencing. Unfortunately, it's not available in Sri Lanka at the moment. We were able to send this sample through one of the private hospitals to India, and we can see that it is Mycobacterium intracellulare and subspecies Yonganense. So patients, the tuberculosis can be mimicked by this. So all AFB positives are not tuberculosis. The other important aspect is it chronic always? When we say tuberculosis, we think that it's a chronic disease. But this 36-year-old presented with acute pneumothorax to the ETU, had subclinical symptoms, small symptoms, but these patients can present to the ETU and the emergency department rapidly with rapid deterioration. And another patient, a 26-year-old, presenting to the surgical unit with acute abdomen. And in this patient, the X-ray was actually taken to detect the abdominal pathology, where we can see air under the diaphragm. But fortunately, the lungs have also been covered during the X-ray, and you can see tuberculosis in this patient. This was actually an ideal perforation, presenting as acute abdomen to the surgical department. Hence, it can present to any specialty, emergency, surgical. And this patient, again, unfortunately diabetic, 38, most likely type 1 diabetic, not properly controlled. Saturation was 93 with 15 liters of oxygen with a high CRP. Obviously, we were thinking about a pneumonia and was started treatment as pneumonia, and this patient proved to be having tuberculosis. So sometimes these patients with tuberculosis can mimic and present like acute pneumonias because of the tuberculosis per se, but most likely because of the secondary infections associated with the the changes, structural changes that are there in the lung, as well as the secondary infections that are there in these patients. Right? And this patient, a 42-year-old, presented with shock to the ETU. In this patient, gene expert was detected, and we can see that the coliform is positive in this patient, ESBL is positive. So if we have not thought about tuberculosis, we probably would have not sent a sample for tuberculosis. And this patient had co-infection with coliforms and sputum gene and tuberculosis as well. And to make matters complicated, he partially improved with the treatment, and the patient was HIV positive as well. So these patients, especially when we have young patients coming with atypical symptoms such as shock, acute pneumonia, always we have to think about the other comorbidities, because this will have treatment implications for our patients, especially when we are deciding the treatment regimes for these patients, starting antiretroviral treatment, and sometimes coexisting other diseases like fungal infections and other disseminated immune deficiency associated diseases. Right? Can it be silent? Now, we were talking about tuberculosis to be a loud chronic disease and then an acute disease. Can it be silent? Yes. Now, this is a 63-year-old lady with hypothyroidism. He didn't complain of cough at all, no respiratory symptoms, no contact history of tuberculosis. Home environment was normal. BMI was low, and this patient was having right bilateral upper zone opacities. But the ESR was high, 90, and the MAN2 was positive. MAN2 cannot be used, as Vatsala highlighted, as a diagnostic feature for active tuberculosis. But sometimes when we are suspecting tuberculosis, it can be used as a surrogate to help us in thinking about the possibility of tuberculosis. So in this patient, we did the bronchoscopy and the BAL, which proved that the patient was having Mycobacterium tuberculosis. So this patient's clinical picture was silent. When the clinical picture is silent, these patients don't come to us. They might go for a knee joint pain or something like to another doctor, and because of the low BMI, also we might have to think about the other possibilities, and sometimes, especially a high ESR without explanation, we might have to think about the investigations and look into the possibility of tuberculosis in these patients. So ESR in my clinical practice is an investigation that I use profusely in suspected patients. If it is negative, you can't completely exclude, but if it is high, I usually pursue a diagnosis, and sometimes it can be polymyalgia rheumatica. We have diagnosed several multiple myelomas, rheumatoid arthritis, and other inflammatory diseases, but I think we have to do that. And many tuberculosis patients as well. And we will go into the extent of doing a bronchoalveolar lavage and three. So when the patient is silent, we call subclinical tuberculosis. There are various definitions. These patients doesn't have symptoms to suggest tuberculosis. And the important thing about tuberculosis that we understood is that, as Vatsala said, we had latent and active tuberculosis. Latent means the bacteria is there, which has the potential to develop in the appropriate setting, which has stimulated our immune system, the T cells, and which can be identified by a MAN2 or an IGRA. But there are now various cascades in our tuberculosis pathological system, latent tuberculosis. And this subclinical category is a very important thing, especially with regards to patients who have a significant contact history. In a patient who is having smear positive contact history, when we screen these patients, radiology is very important, because x-rays are very important, because we might miss these patients if we don't diagnose. And that is one reason probably Dr. Sumal has highlighted, we are missing cases, because for patients who have a high exposure to a smear positive tuberculosis might not have symptoms, and if we don't screen them, we will not identify these patients properly. And this is the highlight of the graph. I think it's very important. Now, when we look at the symptoms, non-noticeable symptoms in 94% of the population, but even when the patient doesn't have symptoms, abnormal X-ray has been positive in 597. This is culture-proven tuberculosis. So in patients who are asymptomatic, chest X-ray will help. And these are the population with having subclinical tuberculosis. What is the clinical implications of it? The most important thing is they can spread the disease to another person silently. So when they have this disease, they can spread the disease to the other person. And it is, I think, Dr. Sumal will agree, it's a public health nightmare because these patients silently give the disease to another person, and it is effectively giving the disease as well. So finally, we can understand the challenges of making confident diagnosis of pulmonary tuberculosis, but tuberculosis is not confined to the lungs. Eye, GU, osteomyelitis, skin, meningitis, spine, pleura, heart, pericardium, genital tract, liver, every part, GU, GI, every part can be affected by tuberculosis. So any specialty, we will be exposed to tuberculosis. And if we don't diagnose it and have a high clinical suspicion, we might miss these patients and have severe consequences for the patient. There was a young child who was, when I was in Badula, who complained of a knee joint. Knee was extensively investigated, but when the child started to walk abnormally, then fortunately the orthopedic surgeon cleverly looked at the hip, and the patient had hip tuberculosis. So sometimes we might miss, but the patient can't actually walk properly. He's a young girl of 9 to 10 years. So there are various ways of tuberculosis and present, but we can't actually go each and everything depending on the time factor. But some of the factors that we highlighted when investigating pulmonary tuberculosis might be able to use, who probably we should have a high clinical suspicion of tuberculosis, because tuberculosis is common in Sri Lanka. It is the most commonest infectious cause of death in Sri Lanka. So we should probably suspect tuberculosis in most of the patients, and they can present in various ways. But having a high degree of clinical suspicion is very important. Even a back pain, whether it is tuberculosis, whether the patient is having headache, whether it's a tuberculosis. When the patient has red eye with poor vision, can it be TB uveitis? Lymph node, obviously, whether it is TB. If we think that whether this can be tuberculosis, sterile pyuria, urine UFR positive, culture negative, yes, we might be able to think about tuberculosis. If a patient is having a pleuritic chest pain and shows pericardial effusion in the echo, whether it is tuberculosis. So there we have to think about the diagnosis. And always, I think it is very important that we have to have a bacteriologically proven diagnosis, and we should actually try to get it as much as possible. Sometimes we might be able to get it ourselves, but sometimes we need help from other colleagues. We diagnosed a peritoneal tuberculosis with the help of the gastrointestinal surgeon. We diagnosed genitourinary tract tuberculosis with the help of GU surgeons, our colleagues in gynecology. We diagnosed basically pericardial effusions with the help of our cardiologists. So, but we try to get a diagnosis as much as possible, the bacteriologically proven. But that doesn't mean that until then we don't start treatment in the appropriate setting. We start treatment, especially if a bacteriologically is not proven, and if we are still suspecting, we will continue treatment with tuberculosis, but we will closely monitor for the TB mimics and the coexisting other diseases as well. It is the most important thing. Tuberculosis, it can pretend, but unfortunately, it can coexist as well. So like that patient, they might present as tuberculosis, but if we don't think about the other coexisting diseases, we might miss these patients. So it is very important that we think, especially lymphoma and tuberculosis can coexist together. Pleural effusions and lymph nodes can coexist together. And it is always better to work as a team. Like here, right, we have public health experts, microbiologists, pediatricians, physicians, and all our colleagues, surgeons coming in together and having a helping hand with the administrators as well. So this is the final slide. I think Professor Ranjit Pereira named it as a Victorian scourge, and this is actually Robert Koch. In the 1900s, he went to the British Parliament to give a speech about tuberculosis, because at that time tuberculosis was a problem in UK, and he said that there is no disease which inflicts such deep wounds on mankind as this. And unfortunately, even after 125 years, it is the same. So it is time that we should get together and do something about it. Thank you very much.
Thank you, Ranjan, for that very comprehensive and um, case-based presentation, giving us examples of different manifestations of tuberculosis. And we move on to the next speaker, that is our final speaker, Dr. Chandra De Silva, who is a consultant pediatric pulmonologist at the Lady Ridgeway Hospital, Colombo. And he will speak to us on tuberculosis in children, unveiling the iceberg, a case-based narrative again. Over to you, Chandra. Thank you.
Thank you, Madam. At the outset, I would like to thank SLMA and the special committee on communicable diseases arranged in this symposium on tuberculosis. So, as you already discussed about the importance of the disease, I just rush through. Especially important aspects related to the childhood TB. As we already discussed, as we all know, there are many challenges. Some of these are very specific to children, especially the presentation of disease. Mainly children then presents with non-specific symptoms, no typical symptoms, no specific manifestations, and most of the time they are overlapping with their common diseases. As you know, the children, especially preschool, yes, they are always having some maybe viral upper respiratory infections, and with that, sometimes TB might be hiding in these children. So, because of that, initially, yes, there's a significant delay in suspecting TB in these children. And even we suspect disease, it's very difficult to get proper samples to get a positive culture, as already discussed. As always, it is wise to advise to diagnose this disease microbiology, because TB is an infection and it's a microbiological diagnosis. But unfortunately, in children, it's very difficult to obtain a proper samples because of this post-specific disease, as well as the difficulty in obtaining samples, especially small children. So because of that, the diagnosis, the delay in the diagnosis of children. And Sri Lankan situations, already discussed about the overall picture, but there's a problem. So as already mentioned, according to WHO estimates, we are missing some of the important proportions of patients with TB undiagnosed. And this is common to children as well. You can see these are the cases, and last is just 231. WHO estimates suggest about 10% of cases should be pediatric patients, but unfortunately, our setup, we diagnose less than 3% of total cases. So are we really missing? Yes, obviously, there should be some proportion, even if not the 10%, but at least few proportions of children are there, we are not diagnosing because of these practical issues. And sometimes they are present in very, very later stages with complete, sometimes destructions of some complete lobe, significant damage to their lungs. I'll show some pictures. So TB in children is always a challenge because of these variable presentations. And other problem is sometimes, unlike in adults, the multiple organ system affections, and especially the disseminated disease and some of the important morbidity causing involvement like TB meningitis is more common in children. If I give some figures, you can see the infants, when the child develop these infections, as you know, there's a delay, some time. It's a continuous process from the infections to develop as a disease. But if it's these infections develop in children or child infected with TB bacillus, there's a high chance of changing or it progressing into active disease, even it's a 30 to 40%. This gradually reduces in address, but especially the small age group, less than 5 years of age. Two things. One thing is progression to the active diseases, as well as, most importantly, the progression or development of disseminated disease, and TB meningitis is also high in the small age group, especially less than 5 years of age. Even though we TB discuss as a single disease, yes, it's a disease, but there's a dynamic continuum from the exposure to the infections, and then sometimes they have this subclinical disease, which is more common in children, and then it leads into the non-severe disease, and finally, if it is not recognized, then it leads into severe disease, as we already discussed, and some meta-analysis also. But children, the problem is this situation is little worse. So with the gradual worsening of the development of the bacteria, especially when the bacteria increases in numbers, the symptoms start to occur, and then with that, the inflammatory process continue from the subclinical disease to active disease, and initially the mild disease to very severe disease. So the gradually bacterial loads increases at the time of presentations, at the time of diagnosis. So this is important. At this, within this spectrum, at which point we diagnose these patients, especially children. Unfortunately, sometimes we are seeing these patients at the end of this spectrum in very, very severe diseases. I will show some examples, right? Yes. So the initial stage, it's a latent TB, just an infectious, no active disease. Organisms are there, but there are no dividing organisms. They are in a dormant state in majority. And then sometimes it started to produce this more damage, and initial presentations disease is there but subclinical states, and then active disease with a mild disease. But if it's not diagnosed at this stage, obviously it can progress to the severe disease. So this is again important, at which stage we are going to diagnose these children, and at whether there is a possibility to prevent these progressions of disease with the gradual involvement of the inflammatory process as well as the increase in the number of these bacilli. If we not diagnose, you can see the damage finally it's happened. Yes. So these infections to the disease is a dynamic condition, especially children. Majority of these children, the progressions happens within first 2 years of primary infections. From infections to the disease, it's usually within 2 years. Out of those, also 90% develop the disease within first year of these infections as a progressive primary disease, and reactivations also possible with some reductions the immune system or the immune deficient status, maybe acquired diseases or due to drugs or some other medications causing. But this is not a common scenario, but a progression of the primary disease as a progressive primary disease is the commonest manifestation in children. So children also can develop all sorts of these intrathoracic manifestations as well as the extrathoracic manifestations, or what we are called is extrapulmonary tuberculosis. So I'll rush through some cases just to show the spectrum of cases that we have come across during last few years in our setups, just to illustrate or just to show this is maybe a tip of the iceberg. There may be some other children, especially the subclinical state is going on, undiagnosed, uncomplicated disease, but sometimes we are missing that stage and they are present with the complicated stages. So this case, 13-year-old girl, Beruella, this child actually had very typical symptoms of tuberculosis, intermittent fever, loss of appetite, loss of weight, going on for about 4 months durations. Many visits to the family physicians, but not identified or suspected or even done a chest X-ray. But child gradually developed weakness in the body and finally end up develop pedal edema. So because of that, someone has suspected cardiac problem and referred to a pediatric cardiologist. Did the echo was normal actually, the heart was normal, but he has detected there were bilateral consolidations, and finally child end up in LRH. So you can see the X-rays, bilateral changes involving extensive changes. Yes, so the CT consolidations, screen bud appearance, very typical of endobronchial spread of these infections, causing involving the almost all segments of the lung, bilateral disease, very severe, active tuberculosis, undiagnosed at the initial stage. Yes, so with this type of cases, it's very difficult to treat, although these child survive, but problem is end up with significant lung damage as well as end up with bronchiectasis of this type of lung damage at the presentations. So this is very late presentations. Similarly, sometimes they have presence with, sometimes it's just the fever only, but intermittent fever, there's no lung signs or the respiratory symptoms. Like this case, 4-year-old boy, it's mainly the chest X-ray revealed the widened mediastinum. And you can see there are multiple lymph nodes involving, but yes, so because it's just a lymph node involvement, no lung parenchymal involvement. So because of that, this child didn't have respiratory symptoms. So because of this persistent fever, just someone has done a chest X-ray and revealed the widened mediastinum, and sometimes in children this widened mediastinum might be missing. So that's one of the important take-home message. Another case, 8-year-old girl, similar symptoms, present with fever, loss of weight, and some respiratory symptoms. You can see there's right middle lobe involvement. Actually, there's a collapse due to lymph node involvement. Finally, gene expert was positive. Another TB case, collapse of the middle lobe, very clearly seen because of the obstruction of the right middle lobe bronchus due to lymph node involving the TB. 7-year-old boy, you can see the typical miliary mottling. Miliary is sometimes we see this type of textbook features involving this. These are actually normal children without, so you, as we know, sometimes this miliary involvement happen with some sort of immune deficiency, but these are children with very normal immunity but end up with this type of extensive involvement of this miliary TB. And this is again 8-year-old boy came with some respiratory symptoms with fever. You can see this X-ray. There's a left lower lobe collapse, and it was confirmed with the CT. And because this persistent fever was going on despite appropriate antibiotics, and because of that, and the persistent collapse, we did a bronchoscopy. And bronchoscopy revealed, you can see there's a mass-like lesions like caseous in the left main bronchus, obstructing the left main bronchus, and Ball was positive for tuberculosis, and we have started treatment, and with that the collapse also significantly reduced. So most of the cases are actually we have success stories, but unfortunately, as I mentioned, and there are a few more cases, the late presentations, like in this case, you can see this is at the time of presentations, involving the bilateral lung field, almost involving the all area. So end up with this type of significant lung damage and bronchiectasis. Even though there would be some recovery, significant recovery is there, but still, especially the teenagers. Another similar case, late presentation, can see how is the damage, the involvements. That's why it's very important, early suspicion of these cases. At least do a chest X-ray, as Dr. Niranjan reiterates. Always we are reiterating, undiagnosed. If a child or the teenage presents with recurrent episodes of fever, loss of appetite, loss of weight, or any suspicions, it's always advisable to do a chest X-ray. There is definitely no harm of radiology doing a single chest X-ray. So another child, similar kind of symptoms, chest X-ray, little non-specific, but if you see it clearly, there are some opacities in right side with little bit of whitened mediastinum. You can see the again mediastinal lymph node here, very typical of central necrosis with rim enhancement, suggestive of TB, gastric aspiratus positive. Another case, can see the left lung, left side, left upper lobe is completely gone. CT confirmed that. You can see the extensive damage to the lung, left upper lobe. So it's very difficult to recover. These patients end up with permanent damages to these children. You can see already develop some bronchiectasis changes. And the same case, you can see the dates, September 9, 2023, that's the initial X-ray. And after 2 years, to August 20, 2025, some regenerations happen, but fibrotic changes. So this is the problem. So they end up with this type of permanent lung damage with the structural changes, and some, as an adult, these patients are end up with chronic lung diseases, restrictive diseases, and if they develop secondary infections, and end up with bronchiectasis changes, ending up with a chronic disease. And the same. So all these are children and adolescents presents with later stages. You can see extensive changes. Just to illustrate, so these are our true patients. You can see another case, bilateral involvement, very late presentations, didn't think about TB, taken treatment from several primary care setups. Yes, so that's very important. Do X-ray. So this is the best presentations to us, this extensive involvement in the X-rays. Another girl, similar presentations, you can see very typical teen but textbook teen but appearance, suggestive of active ongoing infections, and gene expert was positive, bilateral involvement, cavitated diseases in the lower lobes. And this girl, 13-year-old girl, came from Gunasingapura with intermittent fever, loss of appetite, and loss of weight. X-ray, again, typical of tuberculosis in this age. And this is important. So gene expert was positive, and the rifampicin resistance was detected. So this is the first case diagnosed to have MDR TB in a child with a proper diagnosis, and this patient has been treated at Valisera and now completely recovered. So So the MDR TB, although it's rare, although not that much common in our setups, now children also get affected. Actually, this child didn't have any positive contact with MDR patients. So we don't know from where, but that community possible, but there's no obvious direct contact with the MDR case. So those are some illustrations or some examples of the pulmonary involvement. In addition, that there are many extra pulmonary involvement of children. Also, this is a 4-month-old baby transferred from Moragal Hospital. The initial complaint was turning head to side. So there's a torticollis, and initially given some steroids also, and then settled and again present with the similar symptoms. So we did the CT. CT showed C3, C4 vertebral dysplasias. Just a 4-month-old child. Initial presentations was that 3 months of age. So because of these lesions, our concern with the LCHO TB, so the biopsy was done and both expert and the TB culture was positive. So at small age, this age, probably a child acquired the disease from the mother, but surprisingly, we did extensive invasive mother, we couldn't find disease in this child, mother. So, but obviously both expert and the cultures was positive from the biopsy sample. So it's obviously TB. Yeah, this is another interesting case. The 12.5-year-old girl from Ampara, and she has attained menarche recently, and then the presenting complaint was PV bleeding, persistent PV bleeding, and investigated by a VOG, started some tranexamic acids, and persistent enuresis, noctudinusis also there with some hematuria. So because of that, some investigations were done. You can see, we don't have time to go through, but several courses of antibiotics were given. Extensive investigations were done, including ultrasound scan. They planned to do a cystoscopy also, but they couldn't proceed it because of this heavy bleeding. And several investigations, you can see the UFR pulses 90 to 100, but the cultures were negative. UFR persistently pulses were there. So because of that, they suspected tuberculosis, but this was going on. You can see the initial presentations, September 2022 till the March, 6 months. They couldn't obtain a diagnosis of, they suspected TB, but the cultures were negative. So the child ended up with us at LRH. MANT was done, MANT was positive. So the first thing we did was do a chest X-ray. We did a chest X-ray. So you can see there's a opacity in the right upper zone. And so this is the true report. The gene expert was positive. So this one actually had renal TB and the primary involved in the lung as well. And this child was very well responded to anti-TB medicines, and all the renal, the urological complications were settled. Actually, there was no PV bleeding because of this heavy hematuria with the incontinence. They initially misinterpreted as it as a PV bleeding, a heavy hematural lung involvement of the kidney. So, so if you even suspect extrapulmonary TB, always do a chest X-ray. Sometimes you have the answer. So neurological involvement, sometimes we some unfortunate situations, some children extensive involvement like this child, multiple tuberculosis, several times presentations, even multiple occasions developing the symptoms and present with neurological symptoms. Another child, 4-year-old boy, high fever, headache, lethargy, CSF was suggested pyogenic meningitis, but there was poor response to treatment. So because of that, they suspect of TB meningitis. Because of that, they referred to us. But we did a chest X-ray. There was obvious miliary TB. So this type of situations, the diagnosis was very easy actually. We straight away started anti-TB treatment. There's another child, unfortunate child actually, later presentations with features of TB meningitis. And you can see the significant hydrocephalus child has undergone several neurosurgical procedures, but finally succumbed due to severe CNS involvement. So this type of unfortunate situations also can happen with TB, and it is happening in our setup also, even in children. Bone TB, 2-year-old boy, the small age also, the bone involvement, fever, pain, and swelling of left knee joint. You can see there's a lesions involved in the lower part of the femur, and the biopsy suggestive of TB, and even the imaging suggestive of TB. We have started treatment, and after 1 year of treatment, 12 months of treatment, child completely recovered. lymph node involvement, sometimes we get several cases of lymph nodes, sometimes unfortunately they are ending up with surgeon's hands and end up with surgical involvement. But this girl, initially we suspected TB and all the positive features suggestive of TB, gene expert aspirate was positive. Because of that, we started treatment. Even if burst, we didn't do anything, continue the treatment with medical management. It's completely settled. Sometimes this type of skin involvement, this was actually our clinical diagnosis possibility of TB, started anti-TB treatment. This girl from one of the open age. And yes, completely settles with the treatment like that. Some lymph node involvement again. So this type of situations, we have to suspect TB aspirations is enough, and usually we don't need any surgical interventions. Even if, as we know, if we do surgical interventions, sometimes end up with permanent damage and especially long-term discharge in sinuses, chronic sinuses. Like that, another lymph node involvement case, and eye involvement. This primary TB, plictal conjunctivitis, one of the eye surgeons has very correctly spotted this as tuberculosis. Mount was also positive, and yes, with anti-TB treatment, this has completely settled. And last case, sometimes in children, we have some challenges, especially with immune deficiencies. This is a child with 2-year-old boy with MSMD, the Mendelian susceptibility to tuberculosis diseases. You can see this in this child's groin, actually in all in the upper thigh, extensive. Initially had lymph node, and lymph node was burst and end up with this type of wounds. Okay, and the pediatrician has referred to surgeon also, because actually we didn't want to do a surgical referral. Started treatment. The parents also very compliant, and finally with the treatment, you can see these lesions was completely healed. So this type of any type of spectrums, it's very important to identify, and the most important thing is to break this progression. So can we break it at the latent TB level? Yes, of course, especially if there's a family history, family contact, especially index cases there. Family screening is very important. If the child is less than 5 years, positive household contact, start prophylaxis, so that with that we can safely prevent the progression. Now, at this stage, we can arrest that. Or if the child is less than 5 years of age, do a MAN2. If MAN2 is positive, treat as latent TB, we can prevent these progressions. Then, if it miss at that stage, next stage, whether in the subclinical stage, can we identify TB in subclinical stage? Yes, at subclinical stage, no clinical symptoms. Because of that, again, we don't suspect, but again, family screening is important. Sometimes even the child is asymptomatic, there may be X-ray changes. So this stage, we can stop the disease. And at least this stage, if we can identify disease and stop at this stage the progressions to prevent that type of, which I just shown some unfortunate situations. So high degree of suspicion is important in children to tackle TB. So if you have a child, or if you get a child with unexplained persistent cough, undiagnosed pneumonia, undiagnosed chest opacity in chest X-rays, undiagnosed lung collapse or atelectasis, undiagnosed lymphadenopathy. Sometimes lymphadenopathy is very common in children, but if it is persistent more than 2 weeks, especially cervical adenopathy, always think about alternative diagnosis. Or undiagnosed chest infiltrations, unexplained weight loss, poor weight gain, any organ involvement without definitive diagnosis, or PU or pyrexia of unknown origins, always think whether this is TB. That's the take-home message. So it's a complex process. All the, as Dr. Niranjan mentioned, it's a involvement of the specific, especially the suspicion is for clinicians, laboratory diagnosis, some other factors. We have to get all this together to make this picture for a better future of these children, prevent unfortunate situations of tuberculosis in children. Thank you very much.
Thank you, Dr. Chandy Silva. I think for that very comprehensive and case-based narrative, which is very effective in terms of real experience in clinical setting. Can we invite all the speakers to the podium, to the stage, so that we can have a discussion, or any questions can be addressed, please? Yes. Can you check whether there are any questions from the Chetan only computers? Thank you for staying with us, the people who have come physically. And I would like to invite the people on Zoom platform, if they have any questions, to post it on the chat box so that there's Dr. Chamila is their secretary of the committee who will use these questions, and we can try to give an answer to her. To the person's question. So, any questions from our physical audience first? Mike, Samaratha. Yeah.
I'm a physician from NINDT Maligawatha because we used to have quite a lot of immunocompromised patients coming with respiratory symptoms and signs. So most of the times they are immunocompromised. So the ESR and CRP, they may not be raised. So we are treating with antibiotics. But if it is not responding only, that we are thinking of considering TB. So in that case, could it be latent TB, and what do you advise us in treating this kind of patients? Yeah.
Thank you very much for that question. And I think, especially in the immunocompromised states, if we talk about HIV, especially in a context of low CD4 cell counts, sometimes, unfortunately, the clinical presentation is not typical of tuberculosis. They can have atypical presentations. They can have extrapulmonary tuberculosis. And the obvious way of diagnosing these patients is having other investigation modalities. And one of these investigation modalities is urine lipid test, which is unfortunately not available in the Sri Lanka at the moment. And we are trying to get it down, at least in the trial basis. So that if we have, we can actually diagnose pulmonary tuberculosis as well as extrapulmonary tuberculosis. But when we have especially a patient who comes with a young patient, immunocompromised, with, when the patient is not responding to the treatment that we usually give. For example, an acute pneumonia patient, usually the CRP starts to drop down and the patient will be clinically better in about 5 or 6 days maximum. But if this patient is not responding, one of the differential diagnoses of persistent pulmonary opacities, I think, should be tuberculosis. And in these patients, if we can obtain an appropriate sample, like what I do is we usually go for an induced sputum sample rather than just a sputum sample. And, when we look at the sputum AFB, actually our MLTs look at the quality of the sputum. We look at the epithelial cells to pus cell ratio. But unfortunately, when we do the gene expert, we don't do that, even though it is about 10 times more expensive to get a gene expert than this thing. So sometimes, unless we get a proper sample of this patient, sometimes AFP might be negative, gene expert might be falsely negative as well. So then we have to think about getting a good sample. And as I told, sometimes they will be having, the patient is severely ill, they can't give a sample to us. So then if the patient is intubated, what we do is we usually do a tracheal aspirate or bronchial aspirate for that matter. If further we have a high suspicion, but because the MAN2 and everything will be negative with this patient, if further we have suspicion, even I will go to the extent of doing a bronchoscopy, even when the patient is intubated, getting a bowel sample guided by the imagery, where we know how difficult it is to get HRCT. So sometimes we are guided by the chest X-ray, and we can be guided. We can look at where the exact lobe which is involved, and we go for the bronchial velar lavage, get the sample. And I'm really happy and really thankful to Vatsala at Verisara, and especially Dr. Nilanthi Senanayaka at the Faculty of Medicine, University of Colombo. Now I did the bronchoscopies last Friday. Now she has actually WhatsApped me the reports by now. So like that, we have a very good setup. So bronchial velar lavage is the next thing. And if further we are not sure, then we can actually go for a VATS biopsy to see whether there are granulomas, and we can go for cultures as well. So, if we have the clinical suspicion, in justifiable grounds, depending on the risk-benefit ratio, I think we should try to get a bacteriological confirmation. But if we have a high clinical suspicion and the patient's life is at risk, even we can start anti-tuberculosis treatment. And we call clinically diagnosed pulmonary tuberculosis or clinically diagnosed tuberculosis. At that time, after discussion, ideally as a MDT, the treating physician or respiratory physician and the microbiologist can get together, and then we can think about starting anti-tuberculosis treatment at that time. But we'll closely monitor whether the patient is improving or not, because as we know, melioidosis, fungal infections, and other various types of infections can be common in these people with immune suppression. So it's actually like a solving of a jigsaw puzzle. So, but it is very interesting at the same time. Thank you for your question. Yeah.
Where did you find these patients?
Maligavat. It's a renal, yeah. But for the renal patients, the commonest presentation is actually pleural effusion. It is sometimes really difficult to diagnose these patients who are having TB pleural effusions, because some of these, sometimes we have to go to the extent of doing a thoracoscopy. And I actually didn't want to show you some pictures because we have renal patients coming with tuberculosis, as well as malignancies, as well as uremic pleuritis, which is hemorrhagic. So then there are the places for, in a tuberculosis patient, as you know, they have a very high risk of tuberculosis reactivation. And if we delay the starting of treatment of anti-tuberculosis treatment, the outcomes are really, really poor. And then we actually go into the extent of doing invasive investigations in the appropriate setting, including we have access to a medical thoracoscopy. In pleural effusion, we usually do a medical thoracoscopy. And there was last week, actually, we did a bronchoscopy in a 46-year-old patient who is having a left-sided lung opacity. So sometimes they are prone to get malignancies as well, as you know. So we go ahead and do a bronchoscopy. And if we can't get a sample, sometimes we go ahead and refer this patient to our thoracic surgical colleagues. That is a lung. But at the same time, extrapulmonary tuberculosis also, we work as a team. And as Channa correctly said, sometimes, you don't need surgical, cutting. We just can usually use even in a lymph node, we can do a FNA for aspirate and send it for gene expert, because it is positive, then it is positive. So we have several modalities in these patients.
There are
Just to add that, both of us being microbiologists, this is one disease this government, have invested a lot on high quality diagnostics. It is up to us to use it correctly and in a timely fashion, because I think this is the only disease we have put, the state has invested either through grants or funding. They have invested a lot on, high level diagnostics, highly sensitive, because we were, as students, we were only used to AFB in my time. We didn't even have culture. The only place that cultures were done was at Valley 7. And also there was a great delay because the sample load. So I think we should send that message across to everyone that the diagnostic services is not at fault, because so many, it has been decentralized. So we should make use of the proper diagnostics that are available. No other disease has this freely available nucleic acid amplification testing and a wide variety, including for resistance, right? Okay, you can spread the message to your colleagues at whatever place that you're working in, right? Any more questions?
Madam, there are two questions in the chat. One is, if a patient is admitted and pulmonary TB is highly suspected, rather than waiting for early morning sputum AFPs, can we directly send sputum for gene expert?
What's it for you?
Yes, of course, we can.
Yeah, okay.
We can.
And
But good quality samples.
Yes. And
Can I? And for children, that's the first line.
Yes.
Do not send for bacilli or the microscopy. It's always gastric aspirate, but send for gene expert.
Thanks. And this is there's another question regarding actually referrals. When it's a medical officer from periphery, when you send patients to the central hospitals for investigation of chronic cough. The patient had been treated, has been discharged with inhalers without any documentation as to whether that patient has been fully investigated for TB and excluded. So they have suggested, please give a record to the patient what and what investigate. So this is actually not confined to TB. I think it's like our fault. Medical record keeping is a big problem. I think this highlights also the problem, because as Madam says, we invest so much in investigations, but if nothing is recorded, then the patients wouldn't know as well what had been done. And the peripheral hospital doctor is at a dilemma what to do next.
I think Dr. Sumal can, would you like to tell this person, the chest clinic, or what happens when a patient comes to the chest clinic? The question is that when a patient is sent from a periphery, sometimes to the chest clinic or somewhere, there are no documentation given back to the patients in certain instances.
Yeah, as administrator also, we notice this a lot, this issue. Now, that is because, again, as I mentioned in my presentation, that the fragmentation of the services that we are giving, especially when patients are coming from the periphery to the apex hospitals, which we call base hospitals or above. So the back referral system is not that well established. So the patients are sending the feedback going back to is not quite good. But as a remedial action, right now, Health Ministry is working on these aspects and trying to make clusters of the hospitals and developing the information system. Now it is in certain places as well. The pilot projects are going on 2 districts as well. So where the hospitals are linking together with the digital information system and planning to have a digital record for patients. So these records can be visualized from the up end, from the both ends together. And there are the challenge about this is there are several information systems across the country right now. So all are putting into one particular platform and trying best to do it. And another initiative that's going on right now, that the clustering of several hospitals together with like primary medical care institutes, divisional hospitals, category ABC, and being the base hospital, be the apex hospital. So the referrals from these hospitals coming to the base hospital, if the base hospital cannot tackle that problem, to refer to the higher hospitals as well, link it with them. So in time to come, it will sort it out in a way, but I'm really accepting that the issue is there in the periphery as well right now.
And especially, when we think about when the patients are referred by our general practitioners, for which we are really thankful. And, it depends, when they refer the patient to a district chest clinic. But unfortunately, we only have 24, 25 district chest clinics in the whole country. And that is the only clinic where the patient can actually come without a referral. They can just walk in and tell that they have cough, and they will be thoroughly investigated. So in the district chest clinic, which is geared to identify tuberculosis, usually when a patient comes with cough, even without a referral, these patients will undergo a chest X-ray. They will undergo sputum studies, AFB and gene expert, sometimes both together, or sometimes one of the things, depending on the availability. And if the patient has further symptoms and problems, the patient will be shown to a senior person by the medical officer. So that is the current situation. And some of the problems that we have is that sometimes, even though we take a chest X-ray, we can't give it to the patient because it is in the digital system. So sometimes the doctor who refers to us don't have any idea what has happened to the patient. And usually in the chest clinic, they actually give a card saying the investigation findings and the findings. So most likely the patient can go and show it to the general practitioner who comes. So there are things that we can improve. So unfortunately, if the patient is sometimes referred to another clinic or hospital, sometimes the patient might not be investigated in this way. And I'm really happy to note that certain hospitals, have now started what we call cough clinics. One is base hospital Horana, which we were able to initiate, where when a patient goes with chronic cough, the patient are put into a pathway where seen by a medical officer, and it is actually rapidly shown to the patient, and then the investigations are given and investigated. And the other way that the patient can be referred is labeling the patient as presumptive tuberculosis. So in the chest clinic, if the patient is sent as presumptive tuberculosis, we are obliged to maintain a presumptive tuberculosis register and follow up the outcome as well, because we are obliged to do that in the chest clinics. So, there are ways that we can actually improve, and it might depending on the people who are there as well, because all these factors will depending on the person who is actually seeing the patient. But as Dr. Sumar said, we have to correct the system, and if we have a correct system which has a good feedback mechanism, and when we keep people responsible and accountable, if we can keep that, I think we can smoothen the system very thoroughly. Okay.
Can I add? Yes. Sometimes actually some of the clinics, they keep these investigations because sometimes the patients, they miss these investigations, and we face this problem, and the most of the excuse is gangwato town. Some of them even never say in the blood. So sometimes the problem is patients, they might not understand the importance of this investigation. So because of that, some clinics, they tend to keep these records within the clinic. But yes, so the problem is when we are referring these patients, we actually had this now portrayed this, especially the X-rays, the radiological investigations now at least they are in the system, so we can just retrieve within few seconds. So that type of situation we do face. But initially we had these things. They just miss these investigations, especially when the X-rays are printed. They folded it, they couldn't keep them properly, like that. Practice. So yes, we have to all the aspects should be improved. And now the problem is when the patients are referred, we don't have these films. So then the digital, but sometimes we try to get them their phone, because majority of them have the smartphones, and get the photographs and refer like that. Yes, sometimes we have to identify the practical situations, covering the both sides. That's important.
And especially, I think what we have to understand is when we investigate a patient, the gene expert costs about probably 7,500 to 8,000 rupees in the concession rate, isn't it? Concession rate is 8,000, isn't it?
For the patient, it's free.
For the government. Yeah, right. So the concession rate is about I think it's about 7,000. Yeah. Maintenance level. So we'll say about 10,000 rupees per gene expert test, 10,000 rupees. And just test X-ray, if you take it in the private sector, it's about 2,000. Gene expert, yeah. PCR is 32,000 in the private sector. And the chest X-ray costs about 3,000 rupees. So per patient, the government spends about at least maybe 30 to 15,000 for investigations only, without looking at the other administrative costs and the salaries that we pay. So as Madam correctly said, we are spending hugely for tuberculosis in Sri Lanka, and that is why actually we were able to maintain it at this level. But to go to the next level, we might have to think out of the box, and we have to work as a team together.
There are two more.
Yeah.
Sorry.
Yeah.
So the gene expert test, so even though patient is from private sector, we are doing it free of charge. So patient can be referred directly to either to a chest clinic or to Valisara. So we can do free of charge even from the private sector.
Yes, that's what I said. I mean, even in the private sector, Dr. Chandra said, all my Navaloka samples that are referred to my lab, I send it to the faculty. Only they take some 500 rupees for transport. That's fine, because that's perfectly fine. The patient has come to the private sector because we having some assets, so the transport charge is within the okay limit, like.
Yeah, two questions.
More questions,
Yeah.
yes.
If the martyr is more than 5 in a patient with immunosuppression before giving rituximab, is it indicated for TB prophylaxis?
Rituximab, I don't think so, because especially when the patient is being given anti-tumor necrosis factor, that is infliximab, especially because we know that the tumor necrosis factor is very important in the granulomatous reaction in tuberculosis. So especially if we are inhibiting that, infliximab is given, if the patient is having latent tuberculosis, that is in an competent person, we take as 10 millimeters, and an immunosuppressed patient, we take it as 5 millimeters, and these are arbitrary values, or depending on the ICRA, we diagnose whether this patient is having latent tuberculosis or not. So especially if we are giving infliximab and anti-tumor necrosis factor and inhibitors, there is an indication to start treatment for latent, exclude active tuberculosis and start latent tuberculosis treatment before giving these drugs as early as possible. So to prevent this patient going into active tuberculosis. But rituximab, I think it's a CD20 CD20 antibody, so it has not been shown to be causing increasing of tuberculosis.
Okay, thank you. And there's a question, what is the current statistics on prevalence of TB among children?
I think Chan answered.
Actually, I showed the figures. Annually, we diagnose around 300 cases. Last year is 231 cases, and before that 214. That's a total number of cases confirmed when we started treatment.
Okay, that's all.
From the audience.
So NHSL in the microbiology department and as well as in the Faculty of Medicine.
Yeah, we are getting for the last few months. I'm working as a MO dermatology unit. We are sending now last 3-4 months. We are sending the samples to the Faculty of Medicine. We get the report as said the following day. They WhatsApp the report. But earlier we didn't get the reports, madam. When we called, they said they are sending the samples to the chest clinic. The MRI chest clinic. And then when we inquired from the chest clinic, they gave us some reference number to give a call to the Valisara.
So it may be that is because they sometimes those kits go out of stock. Those are provided by the state to the faculty, not that the university buy them. They are provided by the TB program to the faculty. So there was a period, I remember during the crisis time of COVID time.
6 months ago, for the last there was faculty of medicine.
When there are no kits, they would say that refer to the. Then it's only in the central place.
So what is the sample? Is it a sputum?
Sometimes sputum, sometimes the last month I think skin.
Yes, sometimes when both the culture and gene expert requested, and the sample directly sent to Valisara, because we have to divide the sample and to send to for culture and gene. Sure. That may be the reason.
We send separate samples, one for the gene expert and one for the.
Sometimes these tissues, also the peripheral center sometimes reluctant to perform the tissues in their gene expert machine, so directly send over to Valisara because we have to crush the tissues and to get out the micro. Yes, that may be the reason. But sputum usually these peripheral centers do the gene expert. NHSL, one machine, and Dr. Nilanthi at the Faculty of Medicine, she has 2 machines. So, and TrueNet also available at Faculty of Medicine. So, yes.
I mean, just wanted to ask this one because you said that CMC has a lot of cases, and also diabetes have a lot of cases. Elderly patients have a lot of cases, and we are missing. So, do you have an active? Don't you think that the TB control program should have an active TB screening program for these high risk areas?
There is, madam. There are several outreach programs as well as there is a mobile laboratory where the places are identified specially and doing. And out of that, there is also contact tracing procedure going on. When a patient is identified from one particular place, there is a context of that patient is identified. But unfortunately, that the statistics about 50-60% of the contacts could be traced at the right now.
In the CMC kind of I feel.
Not only in the CMC, that even the other vulnerable groups, and that kind of even the HIV patients are getting screened. So what I suggested is we have to go beyond that. Thinking about the other NCD clinics and even the maternal health, child health clinics sometimes would be important to do that.
Yeah, I think because I worked in Nuwara Badul as well as Ratnapura. And unfortunately, when we see the cases, some of the cases are actually exported from the Western province. And now I'm working in the Western province. But anyway, if we can actually control the Western province tuberculosis, I think our country's tuberculosis problem will be over, hopefully. And so actually now we have this respiratory task force with the Ministry of Health. And at the moment, we are planning to go actively to the high hotspots and actually do a chest X-ray, mobile chest X-rays. Mobile chest, because sputum, as Swatsala said, is not they don't like to give sputum, and sometimes it might be negative. So hopefully mobile chest X-rays together with this gene expert in these typical hotspots, even in the CMC area, not all areas are equally affected. There are some areas there might be zero prevalence, but there are some areas that are very, very high prevalence and more than probably high burden countries in the region. Yes.
Like areas like Mattakulya,
Yes.
Dematagoda, Colonna, it's a high prevalent. You know that the
It was
social
discussed
status.
in the recent stakeholder meeting, so I should.
Okay,
This Dr. Misaya Kader and the team at National TB Program. So there were discussions to focus mainly on the CMC area separately because it behaves as a high burden. Like the statistics are similar to high burden country.
Yeah, and even the other areas concerned, like in the Kalutara also, there are certain pockets where the cases are coming up, like Veruvala, Selvat, and so on. So, as you suggested, most of the time, so there should be some tailor-made system to these areas. So we cannot kind of have the blanket system for the entire country, but especially focus on the high vulnerable areas.
Yeah, I think at the highest administrative level, we should refocus our resources. There's a huge amount of resources for tuberculosis. We should refocus our resources to mainly the high burden districts. And if we can do that, I think we might be able to do that. But unfortunately, there are a lot of problems. Last year, we commemorated World TB Day in Kalutara by actually identifying hotspots and going house by house to identify. But unfortunately, the X-ray machine was not working. So there are a lot of practical issues, actually, not someone's fault, but there are a lot of issues. We have the mechanisms in place, but sometimes all these things doesn't come together as it should be. So if we can have a mechanism that is developed, that is foolproof, and if we have a constant aim, like the malaria program that we had, we were able to eradicate malaria, which has a career. But unfortunately, TB is still stagnant, and these efforts are hopefully to reduce that.
Anjit, I want to ask one last question from Dr. Chandler. Did you check their vaccination history of these kids that you showed us 25 cases? Do you have any data on?
Yes, madam. Yeah. Almost all of them have received BCG vaccinations. Yes. The thing was, some communities, most of these cases come from some communities. We have specifically noted that delays diagnosis and present with this type of damaged lungs.
Yes.
Thank you. Okay, I think we have had a very long discussion and very comprehensive presentations, which updated, I think, the people who attended either on Zoom and physically. I think it was a very valuable experience for us in terms of TB still being a problem in Sri Lanka compared to many other communicable diseases. And thank you very much for coming over, all four of you, for making these presentations and spending your time with us on this important topic. Thank you. And Ranjit, over to you. Okay. You want to distribute, as usual, the SLMA appreciation certificates for the speakers?
Can I?